Primary care is really it's your initial it's the initial care that you have that kind of exposes you to the rest of the system. So taking care of your general health maintenance, your wellness exams, and really just being the first touch point for a lot of patients to the rest of the health system.
We will see patients anywhere from newborn up until their hundreds, however old they are. So we do provide the family care, and in fact, some of our practices see mother, father, brother, sister, and all the siblings, and that just helps to keep with a continuity of care. We actually implemented telemedicine, which is allowing patients to do a visit with their provider over their phone or an iPad or any kind of technology that they have at home or their computer. That was something that we implemented basically within a week and across all of our practices. And nationally, you'll see that a lot of primary care and family medicine practices did the same thing. We can do a telemedicine either that way via face-to-face through our special technology, where basically it's like the in-person visit, although you might not have that touch point like you do when you are in person. For other things, there's also the telephone visit. So if there's particular, if you say, oh, I have a sore throat and maybe I need an antibiotic, something more simpler, then the provider can do just a telephone visit and provide that care to the patient. So it really helped us to keep seeing patients. We did slack off quite a bit actually with not having patients come into the practices because they were scared. I can tell you that right now it's safe for anybody to come into the practice, provided they mask and social distance, and we are keeping telemedicine going forward so that it's always an option. And a lot of families who have little children found it a lot easier because you could also do a telemedicine visit with your child as long as you had the My UPMC app. Where we did struggle a little bit was with our elderly population just because they aren't so tech savvy, but we are working through that, and we do help them, that we can get them connected either with a family member or someone else that can help to provide that visit for them.
There was a period of time where we probably got to a point where there was, I would say, a 2 week period where we really had very few people coming in through the doors. But once we figured out how to make sure that patients were reassured that we were screening and monitoring patients beforehand, so every patient is called before their visit to check for some basic things like are they having fevers, have they been exposed to anybody with COVID, and so by doing that, we were able to sort of prevent people who were higher risk to have COVID from coming into our offices and protecting our healthy patients. And so we really utilized telemedicine as a way to keep those who could possibly have COVID home, where they wouldn't continually spread it to other people. And so that gave both patients reassurance that it was safe to come in. And I think probably after 2 weeks of sort of figuring out what the guidelines were, there were a lot of things in the beginning that were just unknown. The guidelines from the CDC, from the government, from the state were all very different and constantly changing. And when we sort of got a handle of that, we were able to, I think, create more confidence in our patients in coming in, and even our providers, I think, felt safe bringing their patients in. In addition to having our patients requiring masks to enter our building and throughout the entire stay, we had, temperature people in the openings of the office or the buildings screening for temperature, and again, asking the questions about symptoms. And then once in, any patient that would be potentially positive, we are using full PPE, face shields, and then of course having those rooms set aside so that they can be properly cleaned. Having people go in through different entrances, doing car visits, so all those types of things that sort of anybody that would be high risk, we could sort of keep them separate from our healthy patients. I think the traditional idea of primary care where you had a doctor, you called if you had a problem, you came in, you paid your copay, you left, and that was it, was really was the model. And what we've established here, and we're part of the patient-centered medical home, which again kind of looks at it as it's a care team taking care of you, not just necessarily your physician. It involves the nurses, it involves OAs, we have case managers and nurse navigators, all people who are looking to make sure that your care is being done properly, making sure you're getting to the appointments that you need to get to, making sure that we're keeping up with the typical health maintenance and safety parameters for medications. So there's a lot more involved than just now the visit. And your primary care provider is really the person who sort of oversees all these people that are involved in your care now.
Yeah, we have a lot of chronic patients that have a lot of complicated conditions, and so helping them to manage their medications and manage those conditions so that they one, stay out of the ER and also stay out of the hospital. So having our patient-centered medical home and that team-based approach definitely helps us to maximize our patients' outcomes.
I think we can get into it as deep as we feel is necessary. I don't think there's ever, as a good provider of healthcare, you have to look at those things. You have to say, okay, is the reason this person's blood pressure is not controlled, is it because they're not taking their medicine because they just don't want to listen to, or is it because they can't afford it, or is it because the only food they understand how to eat is salty, high, processed salty food? And so getting into those things is definitely is important because medicine, especially in primary care, goes beyond just the prescription. And if you're not kind of tackling all aspects of a person's life, you're probably not going to help their health.
We also have access to social services to help us. If patients are having issues because they don't have health insurance, or if they need some kind of care at the home, or even going to, maybe it's a matter of education, especially with the high blood pressure or diabetics. They might not eat properly. Maybe literacy-wise, they're not able to totally comprehend or read the information that's out there, and they just need some extra help.
I mean, when you're talking about determinants, I mean, you're definitely going to think about things like obesity, substance use, and that goes from anywhere from illegal substances to legal ones like alcohol and cigarettes. And I think the other one would probably be mental health. I think that's probably the other big aspect there that we deal with. And I don't think people always come in, they say, I want to see a psychiatrist. And for most of mental health in this community is managed by the primary care teams. And only the real extreme cases make their way to psychiatry, when they're using some very specific medicines. So I think those are probably the three biggest ones that we tackle. And of course, from things like obesity and the substance use or substance problems, you get into some of these chronic medical problems like heart failure and COPD and diabetes. But all of those things, if you look at the actual root of the cause, it's usually coming from those types of issues. Well, very fortunately, we've had a couple of providers who have tackled or gotten really involved in helping manage the opioid crisis and have provided a lot of education to our providers. So at the very forefront of it is we do utilize the PDMP, which is communication between pharmacists and physicians to basically let us know where people's prescriptions are coming from, so you can find out if a person is going to multiple providers or on multiple substances at high risk, that would put them at high risk for overdose. We were very fortunate that we got a grant that allowed us to give Narcan, which is the opioid antagonist, to help people if they've overdosed. So we were able to give that to patients on high doses of opiates. What other things have we done? We also we monitor all of our providers as far as their utilization of narcotics, both in the number of people that are on those prescriptions and also the amount. So we can get a sense if somebody's beyond the typical average for a provider. We can sort of work with that individual provider. We also have protocols in place for refills to make sure that people are also not left without their medicine for long, which is when people are at a highest risk for either seeking other sources. And then we also utilize the other specialists in the area. We have a very good pain management team, physical therapy, occupational therapy, neurosurgery, and neurology. So we have a lot of different specialties that are also involved in helping us with the management of chronic pain.